Start sharing your screen. All right, hello everyone, and welcome to another session of the Virtual Global Spine Conference. On behalf of our co-hosts and our entire team, I'd like to welcome everyone for another exciting session. I am thrilled today to introduce a good friend and a colleague, Dr. Ganesh Shankar from Mass General Hospital. He is a neurosurgeon there with an appointment at Harvard Medical School. He is a complex spine surgeon with special expertise in spinal oncology, really a terrific both clinician as well as a scientist. And we're absolutely thrilled to have him here today to share some thoughts on personalized medicine and spinal oncology. And hopefully, if time allows at the end, I'll also kind of finish up this session with maybe a few slides on some emerging technologies and techniques in spine oncology surgery. So it's a pleasure to have everyone here. As everybody knows, feel free to engage with us in the chat box. And of course, this will be recorded and will be uploaded on our YouTube channel in a few days. So Dr. Shankar, thank you so much for joining us. And it's a pleasure to have you here on Virtual Spine.
Well, thank you so much, Dr. Baaj, for this invitation. As you probably already know, I very much admired what you and the group have done for increasing overall awareness of spine management of spine pathologies, and it's really been a great resource worldwide. So thank you for this obviously incredible privilege to spend this evening with the group. So the topic I'll be discussing today is really what is the current state of the art in terms of personalized medicine and spine oncology. And I'll be talking about a bit of many different things in spine oncology. We'll discuss metastatic disease, primary bone tumors, intramedullary processes, and just really what I want to highlight through this entire session is really just the fact that no matter how we view spine oncology, it's an incredibly team-based effort. It's a multidisciplinary effort amongst neurosurgery, orthopedics, medical oncology, radiation oncology, palliative medicine, pathology. It's really is a team-based effort. But if we broadly define what is precision within medicine, especially with oncology, it's personalizing treatments based on the features of the disease that are specific to that patient. So in the case of spine oncology, oftentimes the diagnosis is established with some kind of invasive procedure. It can be an open procedure or some kind of percutaneous IR-guided procedure to establish a diagnosis and sometimes to reduce the mass effect. This is then followed with some kind of adjuvant therapy that's guided by, nowadays, a lot of molecular information, molecular markers that are obtained with immunohistochemistry or with next generation sequencing, various targeted genotyping approaches. And this ultimately is with the goal of improving the patient's survival and also to make sure that the therapies are targeted in a way to address the disease process while minimizing treatment-related morbidities as well. So the question that I've always had since I was training is really, how do we bring some of the information that we get downstream of an invasive procedure? How do we bring that into the upfront setting of a surgical plan? And is there a way to either expedite that information so that we can get that while we're in the operating room, or is there a way to get that through liquid-based testing strategies as well? It's really hard to discuss anything in spine oncology without paying homage to one of these foundational studies that was published many years ago, but still is quite foundational in terms of how we approach spinal cord compression, whether it's from metastatic or even primary disease processes, primary bone tumors, which is this Patchell study that indicated that patients who had a decompression followed by radiation had a longer functional status that was preserved than patients who just had radiation therapy alone. And when we look at what was defined as a functional improvement, it was really just the ability to walk 4 steps. And the difference between patients who had just radiation alone was 13 days versus 122 days of being able to do that for patients who had a decompressive procedure followed by radiation. And so 4 steps doesn't sound like a lot, but it's the difference between being able to do a lot of very basic ADLs for a patient, whether it's just being able to get to the commode instead of using a bedpan, and those have incredible amounts of impact on a patient's overall quality of life. And so this is what we're trying to preserve for patients, is their ability to do the very basic things that can improve their quality of life. And so the question then is, well, which patients are offered surgery, and then what are the goals? It's metastatic disease is actually quite common as it enters. Metastatic disease involving the skeletal system is quite common. Up to 90% of patients with on autopsy study will have some form of bone involvement. And 10% of patients during the course of their disease will have some kind of symptomatic spine disease. And this is from metastatic disease of solid tumors. And so the management of this type of metastatic disease it's again multidisciplinary. There's some form of palliative surgery, radiation therapy, as well as consideration for systemic agents. And so I want to focus initially on how do we think through a surgical plan for a patient who's presenting with metastatic disease. This is the NOMS framework that I'm sure this group has heard about before, really popularized by the group at MSKCC with Dr. Bilski. Breaks it out into 4 categories that we think through: the neurologic status of the patient, the oncologic status, the mechanical considerations when it comes to spinal stability, and then the systemic status of the disease as well. And so just to focus on the neurologic status, one of the questions that will be raised when meeting with a patient is, well, what can I expect if I have a certain deficit or a certain amount of pain? And so it's important to really understand for patients who present with any type of surgical disease involving various extents of the vertebral column, what can we tell a patient that they can expect following a decompression, especially if they're presenting with myelopathy, which, as again, this group knows, will manifest as some kind of numbness or wobbliness with the legs before there's overt weakness. And so this very nice retrospective review by Dr. Failings and the AO group tracked 142 patients. And what they found is that for patients who had surgical management of cord compression, there was improved ambulatory status up to at least 6 months and improved pain scores up to 12 months. And this came at a 10% complication rate. These are the various exclusion criteria, which will, for anyone who's interested in going through that paper, can go back and see. I just wanted to highlight again from that paper, when looking at patients who were able to walk just 4 steps independently at 6 weeks, 3 months, 6 months, 12 months, patients had an improved ability to complete those 4 steps, even upwards of 12 months out from their index procedure. So we do these procedures to decompress the cord, not just because we're trying to maintain a patient at their current status, but because we're trying to get them better, get them back to some form of functional status that will allow them to tolerate systemic agents that require them to be at a good functional status. And before I move on to the oncologic status, I just want to highlight for trainees as well that the neurologic exam for patients who are presenting with possible cord compression does not end with just a motor exam of checking strength while a patient is laying in bed and saying that it's 5 out of 5 and that they're neurologically intact. The exam is not complete until you get a patient up to see how they walk. And that really uncovers a lot of the symptoms that are arising from cord compression and dorsal column dysfunction. In terms of oncologic status, the question really is it radiosensitive or not? And so many of those exclusion criteria that I shown in one of the previous slides indicates whether a patient has a radiosensitive, like a hematologic malignancy that would respond avidly to radiation therapy. And patients like that may not be ones that will be segregated to a surgical arm because they have a disease process that will respond to a non-surgical strategy. And so when we look at how various solid tumors respond to radiation, they have varying degrees of radiosensitivity. And we'll go on to this in the next slide, but there's some tumors that are very radiosensitive, and there's some that are intermediate to radio-resistant. And so the tumors that the types of tumors that you see on the left, shaded in green, may respond well to like external beam radiation and just conventional radiation therapy. And some of these more intermediate or unfavorable radio-resistant tumors may require much higher doses of radiation, which will then dovetail into a discussion of, well, do we need to decompress the cord before we can safely administer that high dose of radiation? So what are the indications for applying radiation for a patient with an oncologic process? So one might be to treat pain. And so looking at this recent study from Dr. Sagal from Toronto, what his group found is that for patients who are treated with SBRT, or high dose of stereotactic body radiation therapy over 2 fractions, 24 gray total, they had a longer relief of axial pain than patients who were treated with external beam radiation, just conventional dosing of 20 gray over 5 fractions. And so it indicates that for patients who have disease that doesn't cause cord compression, and the ultimate goal is pain control, they can have a durable relief with SBRT. Following, and sorry, before I move on to the right side, radiation therapy can also be used as monotherapy for local control as well. And again, this is for patients who don't have significant cord compression, for patients who have isolated vertebral body disease, and then adjuvant therapy for local control. So this is the group from MSKCC that published this paper now over 10 years ago that showed that for patients who had undergone decompressive procedures, decompression and stabilization, that they were able to have very good local control of the disease if they were administered radiation therapy, and even better better local control when administered high-dose hypofractionated radiation therapy, as shown in the red and the blue curves. And so then the question is, well, what kind of surgery do we tailor, and who should get surgery based on the mechanical findings on the imaging studies? And this really comes back to how is spinal instability classified? And so the SINS scoring system takes into account various variables of the imaging features of location, whether it's at a junctional zone, whether there's pain that's activity dependent, if the bone lesion is lytic or blastic, whether there's some form of malalignment, whether there's vertebral body collapse, and whether the disease involves the posterior elements. And by and large, most patients who present with some form of epidural spinal cord compression will fall in this intermediate zone. Very few of them will demonstrate true frank instability. And so while this scoring system may not really be all that informative for patients who have high-grade epidural spinal cord compression because they fall in this intermediate zone, it can be helpful for patients who have isolated vertebral body disease to ensure that patients are safe to undergo radiation therapy. And so when we have a decision to proceed to the OR, well, what are the types of procedures that a patient may get based on their individual imaging characteristics? So one option is vertebral augmentation to help with axial pain, as you can see in a patient with myeloma who has multiple levels oligometastatic disease with lytic disease involving the thoracolumbar spine. They did well with vertebral augmentation. For patients who have isolated epidural disease without involvement of the vertebral body, they may be okay with just a decompression alone. And for patients who have much larger extent of disease involving the posterolateral elements, and here you can see that the disease is encroaching into the psoas and wrapping around the lumbar roots through the foramen. These are patients who require more extensive resection of not just bone elements that are involved with the pathology, but also they will require a stabilization because of the instability associated with the surgical approach as well. And so then the question is, we got to get this to fuse. You know, there is an ongoing debate about whether we do need to get patients to fuse, but patients are living longer. And so it is important to consider bone graft extenders and how to get the construct to be stable enough, with the possibility that patients may end up presenting with hardware failure at some point, because the systemic therapies are really quite good. And so this is a general rubric that we use in terms of osteogenic, osteoconductive, and osteoinductive properties of bone graft extenders in order to really push the balance towards laying down bone and increasing osteoblast activity. And there's different bone graft extenders that we use in the operating room for any number of cases. And you know, these are widely used even in cases of oncology, except for maybe bone marrow and autograft. But then I'm going to just switch the topic a little bit, because I think this concept of how to get a spinal column to fuse when there is a much more circumferential resection of bone is actually very important, especially when it comes to primary bone tumors, where the oncologic goal is ultimately to obtain a en-bloc resection with wide margins, which necessitates the circumferential resection of the spinal column. And so when we think through what these constructs look like, they're a reconstruction of the ventral column, and oftentimes some form of extensive dorsal column reconstruction as well. But even with our best efforts, if the construct doesn't fuse, and it's just like a bridge, it's that because of the different forces and that are constantly in play in these types of structures, whether it's flexion, extension, rotation. In the case of this bridge, it was drag and lift, and there was imbalanced. Constructs like this will ultimately be susceptible to the same forms of failure that we see even here. So this construct that looked really good within a few months had the ventral column had subsided, and there was also a rod fracture, which unfortunately this video isn't playing all the way through. So this was a circumferential hardware failure as well. So what are the strategies for how we can get patients to fuse, especially in these environments where they may be undergoing some form of specialized preoperative radiation therapy? There may be consideration for various forms of chemo, and there's an extensive operative approach that will devascularize locally the tissue planes as well. And so this is a very inhospitable environment for fusion. And so this is a known struggle in the reconstruction following resection of primary bone tumors. And so when we here we as a group, we have looked at how patients do following these types of reconstructions, and Will Curry, together with Fran Hornacek and Dr. Schwab and some others in our group, have looked at the role of vascularized fibular strut grafts for the reconstruction to improve this rate of hardware failure, which can approach up to 51%. And so with a vascularized fibular autograft, the rates of hardware failure improved, but still with a hardware failure rate of 31%. And so vascularized grafts do tend to fuse better, as shown in various animal models, and this could be related to increased stiffness and increased cross-sectional area, their ability to resist, as a result of those biomechanical improvements, to resist a lot of these types of forces that lead to failure. Vascularized bone grafts have many other properties that I believe stem from the improvements in the cell viability that will ultimately improve the acceleration of the graft consolidation into the opposing end plates as well. But these fibular strut grafts, as I'll show in a video shortly, they're very narrow. And so to improve the surface area of these strut grafts, these fibular vascularized grafts are telescoped within a femur allograft as well to improve, like I said, to increase the surface area. So just to go through a case of this, this was a case that I did together with my orthopedic surgery colleague, Dan Tobert. This was a patient who presented to him actually following an intralesional resection of a biopsy-proven chordoma, and then was sent to MGH for further definitive management. This is what the teams look like. There's many people in the room. We have Dr. Valerio from plastic surgery as well, who's harvesting the graft together with neuromonitoring. We have vascular surgery involved as well. This is stage 1 of a procedure for this patient, where there's an extensive release posteriorly of the dorsal elements, including the transverse processes and the nerve roots, as well as release of the surrounding psoas. As you can see here, we've used carbon fiber instrumentation. Again, just like thinking through what are the unique requirements for this patient down the road, which is the need to continue surveilling for tumor recurrence and not having extensive titanium-based hardware artifact. You can see some of the pedicle cuts through the L3 and the L5 vertebral body. So this is what stage 1 looks like. And then stage 2 is the transperitoneal approach to the front of the lumbar spine. You can see that the IVC has been mobilized over this way. The aorta is coming down here. There's the common iliac. And then the ALL has been sectioned at the L3 vertebral body and down low towards L5 as well. This is then very carefully dissected around not getting into the L4 tumor, and is elevated out completely from the cavity with wide marginal resections, which can be seen on this X-ray, and the tumor margins are all negative. But this is a big cavity, and you can see that right here, which is, for this patient where the oncologic goal is a wide marginal resection. Here's the fecal sac, and on this image you can see the L4 nerve roots coming out. Here's the L3 vertebral body end plate, and then the L5 vertebral body as well. So we need a construct that will span this entire segment. And so this is the drilling out of the femur allograft to allow for a telescoping of the fibular autograft that's vascularized. You can see the artery and the vein, which is telescoped inside the femur allograft to allow for a larger surface area. This is then placed in that cavity, and then the plastics surgery team will perform a microvascular anastomosis. In this case, the artery was anastomosed to a branch of the IMA, and the vein to a gonadal vein. And then the flow through these vessels is confirmed by Doppler. And here's a schematic of what that construct ultimately looks like. And intraoperatively, this is the placement of the construct. This is postoperatively. And the nice thing, again, is just the lack of hardware artifact to buttress the construct in place. We have a carbon fiber plate. And so the reason I highlight that is, again, like every patient, the goals are very unique surgically in terms of whether it's a primary bone tumor or it's a metastatic disease where there's there's a long-term prognosis in terms of a patient who may come back with hardware failure. So thinking and planning ahead in terms of what are the surgical goals and how to achieve those goals as robustly as possible it's an evolving discussion in terms of our appreciation of the biologics and how to get these constructs to fuse. But it's important as surgeons to think through what is the unique goals for this patient and how can we achieve that for long-term oncologic management. This is the part that I really do want to spend some time on. As surgeons, we really think through how do we decompress the cord, how do we stabilize it, how do we get a fusion. But it's really important to work together with a multidisciplinary team of medical oncologists, palliative care, radiation oncology, to really understand what is the systemic status of the patient. And this is the hardest part of the GNOMES framework to really anchor, because it's a moving target as our systemic therapies just keep changing by leaps and bounds every decade. So I'm going to go through a couple of examples of that in this section. The first I just wanted to highlight is that patients who present with metastatic disease and undergo surgical intervention, it's widely published that there are readmission rates, which is a proxy for overall postoperative complications, that approach somewhere in the range of 10 to 15%. And this is from UCSF. We have a group from here, MGH, and then also from the Hopkins group. And so we looked at our own internal cohort here over a more recent cohort, and what we found is that the readmission rate is actually even higher. It's about 28%, of which a quarter of those are related to postoperative complications, and 3/4 of those patients are readmitted for other medical complications that occur, such as pneumonias, lab abnormalities, or additional oncologic treatment. And so the ability to predict which of our patients are at high risk for complications or for readmission it's really challenging. And there's many tools that one could use. And my senior partner and long-term mentor, John Shin, has worked together with his postdoctoral fellow, Eli Masad, to really dig through a lot of the existing frameworks to identify what are the scoring systems that might be most helpful in being able to segregate which patients are at highest risk for postoperative complications. And one of the parts of these scoring systems is they're a little bit all over the map, and some perform better than others in terms of this patient population. The one piece that I think is actually really interesting as it comes out in the literature is really our ability to pick out which patients are frail. And it's hard to really find variables or exam findings or imaging findings that can capture and integrate the concept of frailty. But one marker that I like to use, and is a component of these scoring systems, is the albumin of 3.5, which is a pretty good indicator of overall nutritional status. And so looking at a simple marker like that might actually help segregate which patients might be at a higher risk for postoperative complications. Now, in terms of the systemic status, I'm going to present two different stories in terms of how patients are doing now in the modern era with advances in systemic therapies, and why it's important for us to continue to have a dialogue with oncology in terms of understanding where patients may be in their overall disease course. And so if we look at renal cell carcinoma and metastatic disease to the spine from RCC, these are high-risk lesions. They're incredibly vascular. You can see the phloboids, and these tend to have a pretty high EBL intraoperatively. This, on average, the literature would say that it's at least a couple liters. And I think, for those of us who have been in the OR in these cases, it's likely true that these are very vascular lesions that tend to bleed. The overall survival in this cohort from MD Anderson was 11.3 months. Now, the one thing about this study here is that it was published in a cohort before the advent of some of the more recent therapies that are available for patients with renal cell carcinoma. And so specifically, there's been an explosion over a decade of the various types of therapies that are available for RCC, which really started with tyrosine kinase inhibitors, and then it moved on to various forms of immunotherapy as well. And this changed the landscape of how patients do. So in 2005, patients with progressive disease from renal cell carcinoma had overall survival of 13 months. And by 2015, which is 2 years after the initiation, the rollout of some of these compounds into clinical use, the overall survival for patients with the same status of disease, progressive disease, went up to 25 months. And so how did this ultimately impact our patient population when patients were presenting to us with metastatic disease to the spine from renal cell carcinoma? And what we found is that for patients who presented with options for additional classes of targeted therapies or immunotherapy, as shown in this table over here. If a patient had an option to get another type of chemotherapy or systemic adjuvant, that patient had a longer progression-free survival and overall survival than patients who had no additional options, as shown in blue. So red is patients who got some form of systemic therapy, whether it was a continuation of the same therapy or a switch to one of these other 5 types of therapies. They tended to live longer. And so, one of the fascinating pieces that have come out over I'm going to say now the last 2 decades, just as genomic sequencing has improved by leaps and bounds, and the accessibility is just how much we can appreciate in terms of tumor evolution from the primary site as the tumor evolves and spreads around systemically. And it acquires new mutations that might render it resistant to certain classes of tyrosine kinase inhibitors, but make it sensitive to other classes. And so there's many different options for patients with renal cell carcinoma. And so while we think of our roles as surgeons to be more mechanical, of decompressing and stabilizing, we actually have a very important role in terms of acquiring additional tissue safely during that process to guide these other decisions in terms of other classes of medications that patients can go on, depending on new sensitivities to these agents. And so what about the other side of it? What if patients are presenting to us as a failure with no additional options? And so I'm going to change over to melanoma, which is, again, 15 to 25% of patients with melanoma will develop some kind of disease burden, systemic disease burden. And the outcomes following survival, the outcomes following surgery for metastatic melanoma to the spine was 5.7 months around the time that we did the study, which was just as the field was starting to incorporate more and more immunotherapy into the management of patients who were presented with progressive disease. And so just like renal cell carcinoma, there was an explosion of novel therapies for melanoma, which is a hypermutated tumor, carries the UV signature, and what the impact of these compounds, immunotherapy compounds on overall survival went from 2.9 months of a progression-free survival to 11.5 months for patients who received immunotherapy. So there was a very different expectation in terms of prognosis for patients who are presenting with metastatic disease from melanoma to the spine. And so what we found in our own cohort here is that for patients who presented with metastatic disease, metastatic melanoma to the spine, who presented as an immunotherapy failure, as shown in red, they had an overall survival of 98 days. For patients who are presenting as immunotherapy naive, as shown in blue, they had an overall survival that approached 315 days. And so it was very different if they were an immunotherapy failure versus immunotherapy naive, because it indicated that there was an option for patients to respond to some form of systemic therapy. And so what we believed back then is that manifestation of immunotherapy failure as metastatic spine disease indicated a particularly aggressive point in the biology of metastatic solid tumors. But this is a moving target. For this patient in 2024, the calculus may be very different, especially as we start thinking about additional options such as CAR Ts and other things that might come on the market. So these are the types of discussions that can really evolve for us as a field over time. I wanted to highlight through a case, a patient who presented with metastatic thyroid cancer. It's a 70-year-old who presents with neck pain, left arm paresthesias, and she had no symptoms of myelopathy. And so this is a pretty scary looking tumor, to be quite honest. It's extensive, it's circumferential, it's encasing the vertebral arteries. There is cord compression. But in addition to the disease that she has surrounding the vertebral column and the cervical spine, she also has bulky nodular disease extending along the brachial plexus towards the left shoulder. And so just to integrate some of these concepts that we've been talking about in terms of how to individualize a decision for a patient, this is the neurologic status. She had neck pain, but no myelopathy. She had unilateral radicular symptoms, but it was possibly related to the bulky disease along the brachial plexus. From an oncologic standpoint, the site had already been radiated, and she did have high-grade epidural spinal cord compression. So radiation was not really a viable option for this patient. As I said before, most of these patients will manifest with a SIN, the imaging will be consistent with a SIN score that's in the intermediate zone. In her case, it was a score of 10. And from a systemic standpoint, she had visceral disease involving the adrenal gland and the liver. So it's important to remember this is a team-based decision. And then what are the molecular features of the tumor, and are there options for adjuvants in clinical trials? And so the molecular profiling of her tumor was notable for one of these NTRK mutations, which she had been previously treated with entrectinib for over 12 months. And it was after that that she started to have progressive disease. But the IR guided biopsy of one of these lesions, the C3 vertebral body, revealed the presence of one of these other mutations, which was a G623R mutation that actually rendered it resistant to one of these first generation NTRK inhibitors. So she was then enrolled in a second generation trial of the NTRK inhibitor repotrectinib that can act on the mutated kinase, and she actually had some response of her disease process. And so we didn't end up operating on her, and with the hope that she would respond to the new clinical trial. But I just want to take the discussion even further back, which is, can we identify what targetable mutations or mutations patients may have that could render them responsive to inhibitors or agents that target those molecular alterations without even having to commit to a surgery? And so one of the areas where we struggle is where a patient may present to us and we don't know what the primary site of disease is. We just know that there is some form of cord compression. And so this is a study out of UC San Diego where plasma samples for patients with carcinomas of unidentified primaries were sent for next generation sequencing. So not the tumor, but the blood. And it turned out that when patients in their blood had mutations that could be detected, that also correlated with targets for therapies, like a BRAF V600E mutation, for example, or an EGFR mutation. Those patients had a longer progression-free survival and overall survival than patients who had a mutation profile where there was no targeted therapy, or where a mutation was identified, but the patient wasn't put on a targeted therapy as shown in red. And so this type of study really indicates that perhaps there might be a future where we could think about establishing a diagnosis where we don't really need to focus on doing a surgery to establish that. We could perhaps establish this from either a liquid sample like blood or CSF to help establish a diagnosis to guide therapies. And so we proposed this as a possibility in an article that was published back in 2021 in Blood. And I just wanted to highlight just a few things from that study in terms of what the potential might be going forward. So this is the index case that really, when I saw this in training, I said, we got to have a better way to deal with this type of tumor. This is the spinal cord glioma. The diagnosis is often achieved with open surgery. The therapeutics involve chemotherapy and radiation. And the outcomes are quite poor. They continue to be quite poor, but hopefully will improve with some of the new trials that are ongoing for CAR Ts. But the mean post-op survival is under 1.5 years for patients with spinal cord GBM. And the approach to these initially upfront, as we see in that workflow of surgery followed by chemo and then treatment, is it involves, current state of the art is it involves some form of biopsy. And that's an open procedure. And this is what these procedures look like. This was a patient who presented with a lesion that looked like this, underwent a C3 to T2 laminectomy for a biopsy of an enhancing lesion that was at C7 with a duroplasty and a C2 to T2 posterior segmental fusion. And the pathology was ultimately consistent with a WHO grade 2 astrocytoma, but that was thought to be undergraded because of sampling bias, so was treated as a spinal cord GBM. But this is the type of surgery that I'm hopeful that we can avoid in the future if our liquid biopsies can demonstrate some kind of clinical correlation. So as with any translational project in medicine, these are long journeys. They start with defining the clinical problem, to the preclinical studies, the proof of concept, clinical testing, followed with clinical implementation. And this has been a huge team-based effort by some of the people you see down here and many others who really helped bring a lot of insights that we have in terms of taking discoveries in the lab of what are the markers and the genomic alterations that we need to pay attention to in cancer. And can we translate that to some form of an assay or a diagnostic that can be done in a scalable fashion, that's readily accessible, that can return the information in a clinically meaningful manner. And so that's what we've been really working on over the past decade, is to develop and bring online assays that are very easy to scale. We've decided to use a qPCR-based assay that will identify some of these highly recurrent mutations that are present in brain tumors, spinal cord tumors, or other systemic disease tumors, as well, solid tumors that metastasize to the spine. One of our assays for the diagnosis of lymphoma was actually utilized quite readily when we were just running it in the lab. So we ended up working with our pathology department to CLIA certify it so that the results could then be legitimately returned back to patients. This is a test that was initially started at MGH and enrolled patients from, we started getting samples from the Brigham, just obviously in the same town. But then word started to spread, and we started to get samples from more and more hospitals around the country, with the same hope that one day we might be able to diagnose tumors like lymphoma, or other tumors like the one that we just saw, spinal cord glioma, or another tumor that I'll show in a couple slides, where we may not need to do a biopsy or an invasive sample to establish a diagnosis to drive the next step in terms of therapies. And so this was the hope, that we could take a rapid test that is cheap. I shouldn't use the word cheap, cost effective, it's fast, and it can return critical information that can guide decision making early. And in the current state of the art is, let's say, a brain or a spinal cord biopsy followed with an extensive pathology workup that can take a much longer period of time. And so when we rolled this assay out here at MGH as a clinical CLIA certified test at MGH, we took a process that took 10 days to identify, diagnose a patient, to 2 days to diagnose the same patient, who can then be started on treatment much sooner. And so this has had immediate implications in terms of our clinical workflows here. And this comes back to the dream of what we are trying to solve here, is this problem right here, which is a patient who is quite frail, who presents with leg weakness over several weeks, has a diffusely enhancing lesion with a syrinx along the spinal cord. The question is, can we identify an actionable alteration without having to do an extensive surgery in somebody who's quite frail? And so from a lumbar puncture in this patient, we were able to identify the presence of the BRAF V600E mutation. And obviously this is, it's still considered off the grid, because there's really no precedent for making a treatment decision on data like this, because this is just coming into the world right now. But this patient was discussed at our neuro-oncology board, and the recommendation based on the multidisciplinary group was to actually use this result to initiate BRAF inhibitors to target this disease. And so this is the hope, that we would be able to personalize treatments for patients without having to commit to a surgery. So just in summary, we spanned a lot of topics here, from metastatic to primary to intramedullary processes, but it all comes back to some very basic concepts of really understand the patient's neurologic status. What are the goals of a surgery? Is it necessary based on the radiosensitivity? What is the instability? And then what is their systemic disease status, which is the hardest part to grasp in terms of the patient's arc, the treatment arc, and the disease progression. Primary bone tumors represent a unique set of considerations for reconstruction, and the ability to rapidly and cost-effectively identify molecular alterations in tissue or liquid biopsies can potentially one day directly guide multidisciplinary planning in spinal oncology without the need for invasive procedures. And so that's definitely for us is I would say the holy grail is to be able to get rid of procedures like that. I left my contact information down here in case anyone wants to reach out offline. But thank you again for this opportunity. And any questions at the end, I'll be happy to take.
Thank you, Dr. Shankar. That was really nice. Thank you for all the work you're doing with your colleagues and team up there. Obviously, listen, this is hard, right? I mean, these are some of the sickest patients we see, some that that have a very poor frailty index, and we really need to do a better job of offering the least invasive option. And I'm actually gonna wrap up this wonderful talk. I'm gonna piggyback off your beautiful talk with just some slides here and just elaborate on that a little bit from a surgical techniques perspective, if you will allow me. All right. While I do that, Dr. Shankar, I got a question for you. What is the current thought in your group on, you mentioned renal cell for a few minutes, and what is the current thought that you and your colleagues in your multidisciplinary team have adopted? Are you more towards aggressive on-block resection for that, or are you all leaning more towards SRS, immunotherapy, et cetera? Since you mentioned RCC, and I think that's a common one, that's a common disease that we see. What is the current updated thought, at least from your group, on that?
Yeah, RCC, as you know, sometimes they just don't stop bleeding until you take the whole thing out. And so while we try to go intralesional and try to core it out, sometimes it just doesn't stop bleeding until it's out, and then we're reconstructing with some kind of cage through a posterolateral approach. But if we can get away with an intralesional, that's certainly okay. I think this may be a topic for a different discussion, but having a discussion with the radiation oncologist in terms of what are the goals of surgery preoperatively is actually really important in terms of what they will be able to hit safely and where they're concerned about recurrence based on their CTV, GTV, PTV planning, like what's practical in terms of being able to achieve and to minimize the risk of local recurrence, especially if it's like getting out to the rib head and not just leaving that disease behind.
Got it. Okay. Well, thanks so much again. Thanks for that wonderful talk and bringing some of the basic science of spinal oncology. I'm excited to kind of again piggyback after Dr. Shankar's talk and spend a couple of minutes on some surgical techniques, some less invasive techniques, and how that kind of ties into really a lot of the great points that he just mentioned here in his talk. So, as a lot of you know, from treating patients with, say, metastatic disease or even intradural, intramedullary lesions, we know that sometimes these are some of the more frail patients. They're sick, they have comorbidities, limited life expectancy, poor prognosis. So how do we decrease the surgical footprint? And for some of us who've adopted more of kind of a less invasive mentality, if you will, or less invasive approach in our cases, even in some of our complex cases, I would say that there's probably really no better patient population to implement less invasive techniques on than those cases. So how do we decrease the surgical footprint? Well, number one, don't operate. Don't just like Dr. Shankar said, can we solve some of these mysteries and treat some of these diagnoses without even opening the back or the neck? So whether it's radiation, chemotherapy, immunotherapy, new agents. So, obviously don't operate. When operating, and I think a lot of you here will agree with me, if you've done this long enough, you'll know that sometimes, especially with metastatic disease, less is more. Getting the patient on and off the table is important. Immediate stabilization, limiting the levels, providing that stability is more. You don't want it. There's no point in doing a huge operation on a patient who needs 3 months to recover when their survivability or prognosis is like less than a year, right? And then if you fuse, if you fuse, minimize the levels. But if you don't have to, don't offer fusion at all. And this is these are just a couple of recent studies from our group here on looking at the trends in the surgical management of spinal metastases. There's no question that there is agreement that less is more. Minimally invasive stabilization, percutaneous stabilization, and decompression is really gaining a lot of traction. And in terms of the intradural and even intramedullary tumors, like maybe the ones that Dr. Shankar showed, when I was in training, we used to fuse all those patients. You do a C1, C2 LAMI, you do a 2 or a 3 level laminectomy for an intradural tumor. We were automatically fusing. And I think now we've demonstrated, time and time again that the added time for fusion, instrumentation, fixation is really not necessary as long as you're not destabilizing the spine and removing facets and resecting vertebral bodies, et cetera. So again, a push towards less invasive procedures and techniques. But a lot of the talks I give, I always show these two slides because I think they're really important, especially for trainees, especially for junior colleagues and new surgeons, if you will, in the community, where you want to differentiate yourself. You want to be the MIS surgeon. You want to be the robotic surgeon. And all of a sudden, you lose grasp of really what the tenets of spine surgery are. Even in spinal oncology, it's really the same: decompression, stabilization, realignment. You can't lose track of these. So the wrong question is, well, how do I, differentiate myself and come into town and be the MIS surgeon or the robotic surgeon? That is not the right question to ask. The right question to ask is, what are the principles and how do I achieve these principles with the least invasive way? Again, real quick here in the next few minutes, for me, I have a few themes that have helped me become more efficient, more expeditious in these surgeries. Number one, know the clinical anatomy. If you're going to offer surgery, know the clinical anatomy. Now, a lot of people think that's a cliche, but it's really not, because if you are very adept at the surgical anatomy and the clinical anatomy, you can move quicker. The incisions are smaller. The surgeries are more targeted. So knowing the clinical anatomy is very, very important. Even for benign tumors like this is a schwannoma, a paravertebral body schwannoma. Where is this? What is the corridor to access this lesion safely? Well, there's actually a corridor. There's an infradiaphragmatic paracrural corridor. How do we know this? You spend time in the lab, you look at the anatomy books. And this is something I tell a lot of my trainees. When we were in medical school, you open Netter's or anatomy books and you look at things. There's so much pleasure in going back to these books after training, during training, when you're in attending, because they mean different things to you. You look at things a lot differently. We look at anatomy differently now than we did when we were medical students. So, getting to that infradiaphragmatic retrocrural area is quite easy once you know how do you access that, especially from an anterior and lateral approach. These are just some cadaveric studies that we did, and actually this is that lesion that I showed you. So knowing the clinical anatomy and creating safe surgical corridors is very, very important to doing surgeries quickly. As far as doing corpectomies, whether it's en bloc or intralesional, I like the anterior approach, and we talk about that a lot. But you've got to understand that if you do these with an access surgeon, whether it's a thoracic surgeon or a general surgeon or a vascular surgeon, this is still a spine case. Because that's what they do on a regular basis, they'll create these large incisions and huge kind of shark bite incisions, but the spine is really dorsal. So if you understand the anatomy and how to approach it, you don't need a 15-20 centimeter incision that goes all the way to the umbilicus. You just need anywhere between a 7 or to a 9 centimeter incision. Again, this is some studies from the past here, but knowing that anatomy a little bit better, knowing where the vasculature is, where the canal is, where the vertebral body is, allows you to diminish the size of the incision and get to your target more quickly. And that's all being more efficient and decreasing the surgical footprint, whether this is done laterally, even really for metastatic disease or en bloc tumors like a chondrosarcoma or a chordoma like in this case. Again, I want to stress theme number one, which is clinical anatomy. especially for the trainees, spend as much time as you can in the lab. When you're invited to go to a course with DeVue or Globus or Medtronic or whatever it is, spend that extra minutes, go to the anatomy station, do some extra dissections. I used to do that all the time. I probably still do that, to be honest with you, to do things that I don't want to do during surgery. But I would say knowing the surgical anatomy is really key. And again, we were lucky enough to kind of put together a few papers back in the day, literally looking at the challenging areas: occipital cervical, cervical thoracic junction, lower sacral, and pre-sacral anatomy. That's all part of being less invasive, believe it or not, because it's a targeted surgical operation without much collateral damage. So I'm a big fan of the anatomy lab. I highly, highly recommend that trainees spend as much time as possible in these labs. The second theme here for the next couple of minutes here is technology. And, Dr. Shankar and I share that kind of passion for embracing new technology and new techniques. So let's talk about navigation, robotics. I think your center was one of the pioneers in virtual reality, if I'm not mistaken. So there's a lot of very exciting technology that's available now. When we take a look at minimally invasive procedures, whether it's endoscopy, percutaneous screws, tubular decompressions, we've done this for a long time. Over 30, 40 years, folks have been using tubes to take out discs and do laminectomies. Why not implement these for tumors? Why not implement these for decompressions without having to open to create large incisions with increased blood loss? This was for a degen case, but the point is still the same. These tubular retractors are very powerful, and they can really be have a lot of utility, especially for decompressions that do not require stabilizations. We have a lot of experience in the degen world in percutaneous screws and percutaneous decompressions and minimally invasive decompressions. I think the time really has come, and some centers are already doing a great job with that. The time has really come to incorporate a lot of these techniques, even for tumors. A lot of tumors, as Dr. Shankar showed, there's different types of pain, right? It's neurologic, it's stability. As far as stability, simple percutaneous fixation before a patient gets radiation, for example, or kyphoplasty, sometimes that can go a long way in terms of improving the quality of life. I've seen this especially at the lumbosacral junction, whereas, before, these METs to the sacrum and METs to the lower lumbar spine were just disasters. They're difficult to treat. There's nothing good comes out of, having a large incision there with a decompression infusion. Those are great cases for less invasive percutaneous stabilization, and then off to radiation, off to the systemic therapy or the next paradigm in the treatment. But percutaneous fixation, I think, is a huge game changer in the treatment of mechanical instability with spine tumors. And again, I tell this to a lot of the people I talk to. I don't think there's a greater impact on decreasing the surgical footprint than in spine tumors. So the onus is on us to really adopt and embrace and really improve less invasive procedures for spine tumors. I want to talk about navigation and robotics in the last minute here. I've shown this slide a lot. I grew up, if you will, knowing freehand and doing freehand screws, which I really enjoy. Navigation now, I think, has just made that process a lot quicker and a lot more efficient. People say, well, navigation robotics slows you down. In the initial learning curve, in the initial part of the curve, it does slow you down, but then it actually makes you quicker. It makes you more efficient, less revisions, less takebacks, smaller incisions. All of these surgical themes are so important for patients with especially metastatic tumors. You don't want to take them back to surgery. You don't want to revise screws. You want to get it done correctly from the beginning. So I'm a huge fan of navigation now. We've employed our surgical robotic, our spine robotics program about a year out now. We're a year into it. We use doesn't matter who the vendor is, but we use one of these kind of a table-mounted robotic arm. It's tough. It disrupts your workflow. In some cases, it is slowing us down, but I'm a big fan of it because I do feel that in the next 2, 3, 5 years, as the next iterations come, it's going to make us better. We're going to have more precision, not just with placing implants, but more importantly, especially with spine tumor surgery, it's going to help us plan the resections, plan the osteotomies, plan the en bloc resections. So it's going to be part of the preoperative planning, intraoperative execution, not just placing screws. I just trust me on this. 5 to 10 years from now, placing screws is going to be the least of everybody's concern. It's going to be everything else that comes with that. So we're very excited about all these technologies. I think, especially when it comes to spine tumor surgery, you should definitely leverage both the traditional open as well as the innovative MIS techniques. Focus on the principles, not necessarily the toy or the gadget or the robot brand or the actual technology. Robotics and nav are great. They're never going to do the surgery for you. So if you don't come in with a plan knowing how to execute a surgical procedure properly, you're going to be lost with navigation and robotics. And obviously, it goes without saying, enjoy, like all of us, enjoy what you do and innovate and collaborate. And don't forget that patients come first. And especially our vulnerable patients, our frail patients, such as the ones with oncological processes. So I hope that was just a nice kind of conclusion to the discussion today. Dr. Shankar, any last comments from you, being our primary guest today? Thank you so much for being here and for providing your insight.
No, it's great. I mean, I love all those cadaveric dissections and translation to live patient case. I mean, that's really amazing, and obviously represents a dedication to perfecting the craft, which is a lifelong thing. So.
Yeah, thanks so much. And again, thank you for all the work you're doing in the translational sciences and bringing some of this exciting bench work to the bedside. On behalf of my colleagues, again, thank you so much to everyone for joining us. This will be recorded and it will be up on our channel in the next few days. We appreciate everybody joining us. Have a wonderful evening, and we'll see everybody again next Thursday. Thanks so much. Take care.